those only can be taken as secondary research questions, and that should be directly related to your primary research question. Similarly, once you have defined your research question, you have your objectives ready, your outcome should also be ready, because in PICOT, we are measuring what outcomes we are looking for. So your primary research question should have a primary outcome that is measurable, that is clinically meaningful. You can observe them. It will change your practice, and this also defines your sample size. And that's why I say when you have a research primary outcome, a primary research question, because each research question will have a sample size, and it becomes difficult if you have more research questions or outcomes which are there with you. So primary outcome, be clear that each variable will have different one, and it will become a major issues, and try to have complete primary outcome which is measurable using some validated tool, so that you can easily define them and objectify them, so that whatever you are measuring is quite objective. Now, once you have everything ready, you need to translate into stepwise approach, a step, so that you can now conduct the study, and it will have certain steps and ingredients. Let's see what they are. The basic aspect would be, when you plan a study, remember, the method section should be in such a detail that if anybody wants to do the study, he can replicate in exactly the same way as you have done it. So this means it should have ample detail, so that whatever you have done is being appropriately highlighted into the method section without compromising any deficit or lacuna, deviate the way you have done. Each research question can be answered by a certain study design. You must have looked for prospective studies versus retrospective studies. You may have looked for interventional studies versus observational studies. You may have looked for clinical studies versus basic research studies. So these are different type of studies. They are usually primary researches. Secondary is when you try to assimilate the existing published literature in the form of a systematic review or a narrative review or a meta-analysis. They become secondary research. But primary is what I mentioned. It could be basic, clinical, or epidemiological, and they may be further as experimental or observational. Now, this is how you need to look for that which study design would be the most appropriate for your research question. Now, when we say you are absolutely doing something new for the first time, it's a new technique. Probably it will be in the form of a case report or a case series. And if you have ample number of cases, maybe a descriptive epidemiology. If there is some certain concerns, it will require an animal study. And once you have proven, you generate an hypothesis based on this. You cannot conclude based on case reports, case series, or descriptive epidemiological studies or analytical epidemiological studies. It has to be converted into a hypothesis based on your experience from these, and then you conduct an hypothesis proving studies, which could be clinical trials or maybe a case control or a cohort studies which needs to be done. Now, depending upon the type of research question that you have, you can choose the various study designs. Remember that it is not that you can always interchange whatever you want, but it all depends upon what type of study you are doing it. If you are looking for prevalence incidence, probably cross-sectional surveys are good. If you are looking for causation, risk and prognosis, probably case control, cohort or RCT will be good. If you are looking for treatment efficacy, you are looking for diagnostic test, if you are looking for cost effectiveness of some proven interventions, RCT remains the study of choice. So this is a very gross thing. You need to identify that which study would be the most appropriate for your research question. We had already mentioned your research question stands PICOT format. So based on this, your intervention and outcome, you can take a decision accordingly. You need to manage it. So just to describe what I just mentioned, that once you have initial feel of new intervention, new drug, new technique, you start doing descriptive studies which become hypothesis. Then you find the relationship becomes a case control. Define it means with what changes with exposure. It becomes in those situations the cohort studies. And when you try to link them experimentally versus something gold standard or standard of care, they become clinical trials. So this is how your design study selection for a particular research question will work on these principles. Now, once you have selected the study design period during which your study will be doing, because we know our medical science is changing very fast, and you need to mention during which period the study was done and the area which is done, because many of the interventions and outcomes are affected by geographical area, demographic profile, institutional profile, primary health care centers versus tertiary care referral centers, the type of patients coming to those centers, and hence it has become important, it becomes important to describe where the study will be done. For example, if you are doing a study into a tertiary care center, majority of patients will be referred patients. They will be high risk patients, and hence you cannot generalize the outcome of these patients for a primary care center, because they may not be getting such type of high risk patients there, and study area becomes important. Then define your population, which subjects, participants you will be including into your studies. The criteria for inclusion, exclusion, and discontinuation. This is important because sometimes if a patient is included and that has some confounder for your outcome, in those situations you will not be able to make some meaningful conclusion. You do not know whether it is because of intervention or it is because of the impact of the associate comorbidity. For example, a patient who is smoker and you are looking for any parameters of the lung intraoperatively, and if there are more smokers in one group as compared to the other group, then the patient, the group which has more smokers will have more respiratory morbidity. So it is not because of intervention, but it is because of baseline exposure to a confounder which may have affected the outcome, which is respiratory morbidity here. Hence, the selection of participants becomes important so that your outcome is not influenced by the confounder which is not attributed or acknowledged during the selection criteria. So the data will be collected and what all be included very clearly, because it's important, because the person who is measuring the outcome should be well versed with the technique of those data collection. If somebody is doing an physical examination or looking for a monitoring, looking for a blood pressure measurement, as simple as that, they should know how to measure it appropriately. And this is important that this planning should be clear at the time of initial management itself. And that's why these persons who are involved into data collection, they should be clear about the study tools. Tools means what measurement criteria are you going to look for, what all objective tools you are looking for. If you are using some monitors, how to use them appropriately. What do you mean by systolic blood pressure and diastolic blood pressure or mean? They should be clear so that somebody is not writing mean blood pressure into a systolic one. And the timings. So this all should be very clear in your method section, and the team of researchers who is doing this work should be very clear how to do it. You should have the performers or online filling, or if you want to collect data from your electronic health record system, it should be very clear that how they will be collected through your system. And that should be clear that how those data will be sourced. Now, I mentioned about the measurement tools or the instruments. Now, whenever we say, for example, if you want to measure the blood pressure, you should be clear that how the blood pressure will be measured, because we know blood pressure is measured by non-invasive versus invasive. Non-invasive is also by sphygmomanometer versus automated BP equipments. So this means there will be equipments which works on different principles. Though the outcome, that is the BP reading, remains the same, the same value, but the value may change depending upon what type of measurement tools you are using. So hence you need to have those tools which is standardized, which is best for that particular purpose, which is validated. So whatever tools, equipments you are using, they should be validated, they should be same, and even the method of monitoring them should be also standardized. For example, if you want to monitor the blood pressure, the patient should be sitting, taking a rest for 5 to 10 minutes. 3 readings may be taken, the lowest or average will be taken. So you need whatever you have decided, it should be clear while you're mentioning those aspects. You also need to describe that if you are using lab test, for example, say sugar, blood sugar can be measured from blood values, from arterial blood, from venous blood, from capillary blood. Each will have different readings. Arterial blood gas analysis, arterial versus venous versus capillary, they have different blood sugars, and hence you need to mention clearly that what tool was used, what test was used, which sample was taken, so that they remains uniform. If some patients have arterial blood, some patient has venous blood, some patient has capillary blood, it will be an issue. Similarly, if you are measuring a blood patient in a septic patients where the perfusion is very no compromise in the distal peripheries, and if you measure capillary from there, it may not show the appropriate values, and hence you should be very clear. Also remember that when you want to do a study, appropriate approvals must be taken before you start the study. Whether it is ethical approval, trial registration, institutional review board, or animal committee, depending upon if it involves the animal or if a new drug, the drug authority approvals. These all approvals must be taken with a confidentiality clause that patient's individual condition, data, or information will not be shared. So this is very important. In case if it is not possible, it should be explained to the patient very clearly as why they this confidentiality cannot be secured, and they have to be very clearly mentioned and consent taken appropriately. Now, once you start collecting data, the data that you collect may be of qualitative versus quantitative. Remember that when we say quantitative data like the hemoglobin values, the height, the length of hospital stay, they are quantitative data. Qualitative means gender, blood group, mortality, yes or no. This becomes the qualitative. Remember that we can categorize the quantitative into qualitative because, for example, say blood pressure, you can categorize them as normotensive, hypotensive, and hypertensive. But the vice versa may not be possible. So you need to remember that depending upon your research outcome, research question, the answer that you want to do, you need to collect data appropriately. Because once you have collected data saying hypertensive versus normotensive, you cannot say what was the difference in the blood pressure because your data is not there. So define your variables clearly from the beginning itself. Very important. Whether it's age, nutritional status. So there are a couple of things. One, define them. Second, choose an appropriate tool for them. The measurement tool should be standardized and it should be done uniformly. Whatever variables are, you need to do it. Now, then comes the time you need to sample, randomize, allocation, conceal, and blind it. So these are again different aspects that should be included specifically when we talk about the randomized control trial. Sample means a lot of patients will be coming to your hospital, and when these patients are coming to your hospital, you may be taking some patients. So you need to sample them, and because we cannot study the universe, we'll be taking 100, 200, 500 patients out of millions, then billions of population, and hence we need to sample them. And this criteria should be predefined so as to have equal chance of every observation unit to be part of your study. So this has to be done in a way that you are not biased in sampling, selectively looking for patients who comes to your OPD or clinics, and hence you should be very clear. Sample size calculation has to be done. It cannot be small or large because when you do analysis, a small sample size may not reflect significant value, and large size is unnecessary wastage, and they can also exacerbate the values that you get. So your sampling should be appropriate, of appropriate size, and you can use various sampling techniques that are available. Uh, Probability versus non-probability. Non-probability samples are where the rare disease, small population, specific population like patients who are suffering from some rare disease, you can choose them. Probability sampling is more commoner one where it's a gold standard and it remains scientific basis, and you need to use methods like simple random sample or systematic sample or stratified. Now, when you think your patient selection has some parameters which may affect the outcome, maybe for example, age, you can stratify them. 15 to 45 years and 45 to 60 years, you can do a stratification during the randomization process. Now, once you have looked for the sample is with you and it's in a randomized controlled trial, the patient population needs to be randomized into the groups. It cannot be done arbitrarily, and this process is called randomization. This means you are randomizing so that you can compare with some control. So they are usually multi-group designs where you compare at different intervals of time, and you want to compare because you want to say something is good, bad, or better. So this means you have to compare something. So that's why you need a control. And that is what, when we say control, there needs to be randomized, where you will say one patient, one group will be standard of care, which will be control. The other group will be wherein you will do your interventions, and that will be a study group. And that is how you can choose the control versus a study group. This is also important because some of the factors can have a placebo effect. If you talk to patients, the blood pressure sometimes comes down if you reassure them, if you console them, if you explain them they have good prognosis. So this means without even intervention, which is if it's a pharmacological intervention of antihypertensive drugs, but it is your counseling also which is affecting the outcome. And hence these type of effects also should be looked for where you can include them. Now, randomization is primarily because when we do it, we mentioned that there are certain factors which probably could have affect the outcome. Certain are known. We say you are balancing them. Certain there are unknown. You may not know whether they have affected the outcome or not. You want to balance them also, and this is what the randomization is. You need to randomize them. Most commonly, we use nowadays the software. This software will randomize your patient numbers into two or more than two groups, depending upon your study design. Earlier days, we were using random number tables. Tossing or chit base is not a good not a good option. This was the random number table that was being used. This is stratified, I mentioned earlier. Where you have any concerns, you can further divide them into, say, here we are randomizing them into genders because it appears that gender may have influence on the outcome. So we are already stratified so that each group will have similar number of genders in both the groups. Now, once you have done randomization, you should also be very cautious about the allocation concealment. Now, allocation concealment means that in this situation, whatever you have randomized, the researcher should not know that which intervention this patient is receiving, because there could be some researcher influence, and hence they should be concealed whatever the group has come up, because if they know, the influence of measurement or the intervention can be there, and hence selection bias can happen. So that's why allocation concealment should be done. It means that the knowledge of the forthcoming assignment is concealed from the researcher. He doesn't know whether it goes into a control group or it goes into a study group. There are various methods of doing it. People do most commonly the snooze technique, sequentially numbered opaque sealed envelopes, and they can whatever the number comes, each number is put into a chit. They are closed into an envelope which is opaque. They are sealed and they are numbered. So whenever a patient comes, they are recruited. They come for intervention. You open and see which group it's. So now the patient is already with you, randomized part of your study. The intervention now comes. So you are not able to know that which group is there, so that you may not exclude even before the intervention is done. So this is how the snooze techniques follow the allocation concealment, because remember that sometimes by opaque envelope people can see and there can be some selection bias. Next comes the blinding and masking. Now, earlier days we used to use single blind, double blind, triple blind, but nowadays what we say is that all patients should be blinded from the researcher to know what intervention are. So researcher, patient, those who are doing the cases, the statistical person, all those should be blinded from what intervention they have received, so that they are not aware what intervention, and then they can take an unbiased observation or analysis without. So blind as many as individuals possible into a trial. If not possible, like for example, certain technique where you know that this technique is being done, in those situations, try to standardize the treatment. Use very objective tools. For example, if you are measuring time, do a video recording and let somebody assess those video recordings and know that you are in the right way. Now, blinding versus allocation concealment, they are two different things. Allocation concealment is prior to the patient is included. Blinding is once you have started doing your intervention. So they are two different things, and both has to be done when talk of RCTs. Similarly, are bias and confounders. Now, these are important. I mentioned about the confounders earlier. A little term or little information about the bias also. So, bias could be at many places: patient, physician, statistician, and these biases can be of different types. Now, here what we are talking about is the physician bias or the patient bias, like selection bias, measurement bias, observer bias, recall bias. I mentioned few of the things earlier that during measurement we should use an objective tool, we should have a diary, we should have a structured questionnaire. So this will take care of the biases in these group of patients and hence should be used appropriately. Now, confounder is important. You need to identify because they may affect your outcome. If anything which affects your intervention and outcome both, then it becomes an issue. For example, smoking has some relations with the coffee consumption, they have relation with the pancreatic cancer. But if you're looking for effect of coffee on pancreatic, but since smoker is a confounder here, if you don't take care of it, it can influence both. And this is called confounder, and hence you should be taking care while you are managing your patients. Data quality. Get your data, record your data more appropriately. Wrong, missing data, wrong entries. This is important because they may affect, alter your analysis. And hence, data checking or scrutiny is very, very important. Whether you are looking online or onto papers while entering to the Excel sheet, because all analysis will be done. If they are wrong or missed, then it will be a major issues. Now, coming to the validity aspect. Now, validity, we usually use two terms, internal and external validity. Internal validity is primarily related to what your methodology strength is there. This means if somebody repeats, they found the similar results, it becomes important, they are not affected. External is how these findings can be applied to individuals and setting beyond those studies. So whether if you have done study in a cohort of population, whether the other population will have similar results. So this depends upon when we talked about sampling earlier. So sampling should be appropriate so that the sampled population is informative or representative of the whole population. Sample size. Now we mentioned about sample size. It should be done at the design stage because your primary outcome or primary objective is defined. The hypothesis is answered by this itself. If it is undersampled or oversampled, you will not be able to mention it. There are many formulas available, but nowadays again, we are using softwares which can determine the sample size. But when you determine the sample size, this is the information you should be clear. Certain information has to be fed into these formulas or software that will give you the appropriate sample size, and then you do analysis. This is a big topic. I may not be going into detail because this is a big workshop of the analysis itself, and hence the analysis should be done. Nowadays, most of the analysis is done using softwares like SPSS, R, so they can be done, but you should know how to use the correct test for them. Do follow the ethical principles, which requires the patient confidentiality, the approvals, the autonomy, the disclosure to the patients, and all the trial approvals must be taken before you start the study. I leave it to you at this slide. This is an important slide where they are reporting guidelines. So, for example, when you do a randomized controlled trial, consort guideline is the most important one, which is you need to follow it. It's a checklist. It is a checklist. So when you plan a study, this is though a reporting guideline, but even during planning phase, ensure that all the statements in the checklist are being followed at the same point of time. And hence, you are not missing later on because once a study has been done, you will not be able to go back. And this is where, depending upon your study design, you can look for that which type of reporting guidelines are appropriate. This is available at www.equator.network. This is a good website, Equator Network, where you will find a lot of information related to these various aspects. So to summarize, when we say a study, a well-planned study, it should be well-planned, it should be well-designed, and then you can subsequently conduct, complete, analyze, and publish so that you are able to look for the a robust study which has some good clinical implication. So this is in brief the stepwise approach. I am sure that you will be able to now follow the methods, the ingredients of these, and so that you are able to manage your study design into a more robust, scientific, and it gets published in a good journal. So I stop it here, and we are open for any questions or any comments we can clarify.